Welcome back to the Deep Dive. Today we are opening a file that, I have to be honest, when I first saw the title, I thought, okay, this sounds like the driest chapter in a medical textbook. We're talking about acquired neck swellings. And I can practically hear you right now thinking, a lump in the neck? How complicated can that be?
Yeah.
You get a lump, you see a doctor, end of story.
It sounds incredibly mundane on the surface, doesn't it? But that is exactly where the trap lies.
That's what I realized about 5 minutes into the stack of clinical guides and surgical notes you send over. This isn't just about lumps. It's actually a high-stakes logic puzzle.
It is.
It feels less like a dermatology appointment and more like a detective story, where the clues are hidden in plain sight, right there under the jawline, and the clock is just ticking away.
I'm glad you picked up on that detective aspect, because that's exactly how a clinician has to approach this. It's one of those topics in medicine that really separates, the novices from the experts.
Right.
You see, a neck swelling in an adult is never just a swelling. It's a signal. It's a flag being waved by the body. And the reason we're doing a deep dive on this, our mission for today, is to navigate the landscape of these lumps.
Okay.
We need to look at the clinical presentation, the incredibly complex anatomy of the neck, and then the surgical decisions that follow. Because if you make the wrong call early on, the consequences can be, they can be catastrophic.
You brought something up in the pre-show notes that actually stopped me in my tracks. You called it a golden rule. But to me, it sounded more like a warning siren. It was specifically about adults.
Yes. This is the hook. This is the absolute why it matters. If you take nothing else away from our conversation today, you have to remember this one sentence.
Okay.
In an adult, an acquired neck swelling is malignant until proven otherwise.
Malignant until proven otherwise. That's terrifying. It just frames the entire conversation in a totally different way. We are not talking about swollen glands from a common cold here.
Exactly. And that distinction is vital. If a 5-year-old child comes in with a lump in the neck, 9 times out of 10, maybe even more, it's inflammatory or congenital. It's benign.
Right.
But the statistics, they flip completely once you hit adulthood. In an adult, especially someone over the age of 40, that lump is often representing a significant infection, maybe tuberculosis, or, like we said, malignancy. So the stakes are incredibly high.
So if you miss it,
if you miss the signs or if you misinterpret the texture of the lump, you could be delaying a life-saving cancer diagnosis. Or worse, and we'll get to this, you could intervene surgically in a way that actually spreads the disease.
Okay, let's unpack this. We have a lot of ground to cover. Looking at the roadmap for today, we're going to try to organize this chaos a bit. We'll start with the classification of these swellings, which seems helpful just to get our bearings.
Good place to start.
Then we're going to get into the specific red flags for cancer. We have a section on what you call the do not touch lesions, which sounds ominous. And finally, we'll look at the specific traps that trip people up, whether they're medical students taking exams like the USMLE or, doctors in a busy clinic.
That's the plan. We need to move from that big picture right down to the granular detail.
We'll start with that big picture. Section 1, classification. When a patient walks in with a lump in their neck, how do you even begin to sort through the possibilities? My brain would just be firing off guesses. Is it a cyst? Is it a muscle knot? But I assume there's a rigorous system.
There is absolutely a system. You have to organize the chaos. If you try to memorize every single disease that causes a neck lump, and there are hundreds, you'll fail. It's impossible.
Right.
Instead, we braid it down into the big 5 categories. This is the standard framework we all use.
The big 5. I like that. Who are the players?
Okay, so number 1 is inflammatory. Think infection, redness, immune response. That's bucket 1.
Got it.
Number 2 is neoplastic. That just means tumors, both benign and malignant. Number 3 is vascular. So these are issues related to the blood vessels, the arteries, and veins in the neck.
Right.
Number 4 is traumatic. Pretty straightforward injuries, hematomas. And number 5 is the catch-all. Miscellaneous.
Miscellaneous always feels like the junk drawer, but I assume there's important stuff in there too.
There is. Things like goiters, thyroid enlargements, or harmless fatty lumps. But having these 5 buckets allows you to instantly narrow your focus. When you look at the patient, you aren't just guessing. You're asking yourself, does this fit in bucket 1, inflammation? Or does it seem more like bucket 3, vascular?
And all of this is viewed through the lens of age, right? That seems to be the critical filter.
Precisely. The approach changes entirely based on the patient's age. If that 5-year-old walks in, I'm thinking bucket 1, inflammatory, or maybe something from bucket 5, a congenital thing they were born with.
But the 50-year-old?
The 50-year-old walks in, I am immediately on high alert for bucket number 2, neoplastic. The high risk in adults drives every single decision we make. It biases our investigation toward ruling out the worst-case scenario first.
Okay, so we have our buckets. Let's dive into the first one. Section 2. The fire in the ice. This is our inflammatory swellings. I called it that because the notes distinguish between acute and chronic inflammation, and they seem to present in just completely opposite ways.
That's a great analogy, actually. Let's start with the fire. This is acute inflammation. The clinical picture here is what we call acute lymphadenitis, or if it progresses, a neck abscess.
And this is the one that's hard to miss, isn't it?
Yeah.
It's loud.
Usually, yes. The signs are classic. In Latin, we call them rubor, calor, dolor, and tumor.
Which means?
Redness, heat, pain, and swelling. The skin over the lump might feel hot to the back of your hand. The patient is usually complaining that it hurts, often quite a lot. They might have a fever. It's an angry-looking thing.
So, the aha moment here is the pain and the heat. If it hurts and it looks angry, you should be thinking inflammation right away.
Precisely. Pain plus redness equals inflammation. It's a very reliable correlation. And the action plan is pretty straightforward. You start with antibiotics to fight the infection.
Okay.
However, if it's already turned into an abscess, which is a walled-off collection of pus, then antibiotics alone won't fix it. The drugs just can't penetrate that wall effectively.
So what do you do then?
Then you need to perform an incision and drainage, or an IND. You have to physically open it up and let the pus out. There's a very old surgical adage. Where there is pus, let it out.
Simple enough.
Yeah.
That's the fire. Now let's shift gears to the ice. This is subsection B, chronic inflammation. And specifically, the source material really highlights tuberculous lymphadenitis, TB. I think a lot of us think of TB as a lung disease, someone coughing up blood in a 19th century novel. I didn't realize it was a major player in neck lumps.
Oh, TB is a master of disguise. It affects the lungs primarily, yes, but it can affect almost any organ, including the lymph nodes in the neck. And we call it the ice or a cold abscess because, unlike the acute cases we just discussed, these swellings are often painless.
No pain at all.
Often no, they're slowly progressive. They just kind of sneak up on the patient over weeks or even months.
That sounds dangerous. If it doesn't hurt, you might just ignore it for a long time. You just think, oh, I have a weird lump, maybe it'll go away on its own.
People do that all the time.
So how do you identify it if you don't have the pain and the redness to guide you?
You have to rely on your fingers. You have to actually feel the texture. The key identifier here, and this is a term that comes up constantly in exams and in clinical practice, is matted lymph nodes.
Matted, like tangled hair or felted wool.
Exactly like that. In acute inflammation, the nodes might be discrete, sort of separate little marbles rolling under the skin.
Right.
In tuberculosis, the inflammation spills out of the lymph node itself and affects the surrounding tissue, a process we call periodonitis. This causes the nodes to stick to each other and to the surrounding muscles and skin. They clump together into a single, irregular, lumpy mass.
So if you feel a matted mass in the neck, your first thought should be tuberculosis.
Your first thought, it's a hallmark.
Okay, so matted equals TB. Now, what happens if you just let it go? Does it stay a lump forever?
No, eventually the tissue inside breaks down and liquefies. It forms what we call a cold abscess. It's filled with pus, but again, it lacks that angry, hot redness of an acute bacterial abscess. It might just feel soft or boggy under the skin, and this leads us to a massive surgical trap.
I saw this in the notes. It seemed like a huge warning sign. Do not cut, which feels so counterintuitive because you just told me for the fire abscess, we have to cut and drain it.
Correct. And that is exactly why this is a specific trap set for students and a mistake made by inexperienced surgeons. If you see a matted node or a cold abscess and you mistake it for a regular boil, you might be tempted to just cut it out, to do a wide excision or a standard drainage.
And that's wrong.
That is absolutely not the treatment for TB nodes.
Why not? I mean, if it's infected tissue, why not just remove it?
Because TB heals very poorly with surgery alone. If you cut it out without treating the underlying systemic infection with medication, the wound often fails to close. You end up with something called a sinus, a non-healing tunnel from the deep neck to the skin that just continuously drains pus.
Oh, wow.
It's a mess. And it creates a permanent scar and a chronic, difficult problem for the patient.
Yikes. So surgery can actually make it worse.
Right.
What is the correct management then?
You need a diagnosis first.
What?
We use something called FNAC, fine needle aspiration cytology. You take a tiny needle, you suck out some cells, and you look at them under a microscope. Once you confirm it is TB, the treatment is medical. It's anti-tubercular therapy, a long course of specific antibiotics for several months.
So drugs, not knives.
Drugs, not knives. Surgery is limited strictly to a biopsy or draining an abscess if it's absolutely necessary, but it's never the primary cure.
So fire gets antibiotics and maybe drainage. Ice gets a needle test and long-term medication. That is a crucial distinction to make.
It is, and confusing the two is a classic way to fail an exam or, more importantly, to mistreat a patient.
All right, moving on to the bucket that scares everyone. Section 3, the danger zone, neoplastic swellings, or, in plain English, tumors.
This is the most important section for adult patients. Remember our rule, malignant until proven otherwise.
Let's start with subsection A, metastatic nodes. The notes say this is the #1 suspect. That implies that if I have cancer in my neck, it probably didn't even start there.
Yes. That's a very, very important concept. If an adult presents with a neck lump, statistics say the most common cause is actually a metastasis, meaning cancer, that has spread from somewhere else and has lodged in the cervical lymph nodes. The lymph nodes, they act as filters. They catch things. And unfortunately, one of the things they catch is cancer cells that are drifting from other parts of the head and neck.
That's so interesting. So the neck lump isn't the source, it's the signal. It's the smoke, not the fire.
Perfect analogy.
How do these feel compared to the other lumps we've talked about? We had tender for acute, matted for TB. What does a metastatic node feel like?
So the texture test here is very distinct. Metastatic nodes feel hard. We describe them as stony hard.
Stony hard.
Like a little rock under the skin. They're usually non-tender, so they don't hurt, and they are often fixed.
Fixed meaning?
Yeah,
stuck.
Exactly. Stuck. Immobile. A benign lump, like a cyst, it usually slides around under your skin if you push it. A cancerous node invades the surrounding muscles and structures, and it anchors itself down. So you have a hard, painless, fixed lump. That is the classic presentation of malignancy.
Okay, hard and fixed.
Yeah.
That's the red flag. So if you find one of these, you said it's a secondary deposit, that means there's a primary tumor somewhere else. Where do you even begin to look?
That is the detective work. You have to hunt for the primary. Since lymph flows downward, the most common sites are in the head and neck region itself. You have to check the oral cavity, the oropharynx, like the tonsils and the base of the tongue, the larynx, which is the voice box, and the thyroid.
So the doctor shouldn't just be poking the neck. They need to be looking down the throat, checking the tongue, feeling the thyroid gland.
Absolutely. You cannot treat the neck lump in isolation. You have to find where it came from. Sometimes the primary tumor is tiny, almost invisible, but the neck lump is huge. We call that an occult primary. The management usually starts with an FNAC to confirm it's cancer, but the ultimate treatment, whether it's radiation, chemotherapy, or a big surgery called a neck dissection, it depends entirely on where that primary tumor is hiding.
Right. And just to be clear, subsection B mentions primary tumors as well. So these are tumors that actually start in the neck structures. Is that right?
Yes, though they're less common than metastases, the swelling could be the primary source itself. We're talking about things like thyroid tumors, salivary gland tumors, or soft tissue tumors like sarcomas.
And the advice here in the notes is always localize the swelling to a specific anatomical structure.
This is where anatomy is king. The neck is packed with structures. If the lump moves up and down when the patient swallows, it's almost certainly attached to the thyroid or the larynx because those are the only structures that move with swallowing.
Oh, that's a neat trick.
It is. If it's high up under the ear, it might be the parotid salivary gland. Knowing your anatomy instantly narrows down that list of suspects.
Got it. So hard and fixed is bad. Look for the source. Now let's move to section 4. This one has a very dramatic title in our outline, the do not touch zone. These are vascular swellings.
Yes. This is a very high yield differential, which means it shows up on tests all the time because missing it is, well, it's catastrophic. We're talking about things like carotid body tumors and carotid aneurysms.
Carotid, as in the main artery that's feeding your brain.
The very same. You do not want to mess around with these things.
So how do we identify them? If I'm feeling a lump, how do I know it's a loaded gun and not just another lymph node?
There are some very clear telltale signs. The most obvious one is that it is pulsatile. You put your hand on it and you can feel it expanding with every single heartbeat.
So you can feel a pulse in the lump.
Yes, what we call expansile pulsation. It's not just being pushed up and down by the artery underneath it. The lump itself is physically expanding and contracting.
Like a little heartbeat in the neck.
Exactly. And if you listen to it with a stethoscope, you might hear a bruit. That's a specific medical term for a whooshing sound that's caused by turbulent blood flow, whoosh, whoosh, with every heartbeat.
Okay, so if it pulses and whooshes, we're in the vascular bucket, and here comes the major safety warning. The notes have this in bold, all caps. Pulsatile neck swellings should never be biopsied.
Never. This is a life-saving rule. It cannot be overstated.
Well, what happens?
If you stick a needle into a carotid aneurysm or a highly vascular carotid body tumor, you can cause uncontrollable catastrophic hemorrhage. The pressure inside the carotid artery is incredibly high. If you puncture it or a tumor that's being fed directly by it, the patient can bleed out in minutes, right there on the table.
That is a vivid and terrifying image. So, no needles? What's the correct path then?
Imaging is mandatory. You do not pass go, you do not collect $200, and you certainly do not pick up a scalpel or a needle. You send them for a Doppler ultrasound or a CT angiography. You need to see the blood flow on a screen.
And surgery?
Surgery, if it's needed, has to be incredibly carefully planned by vascular specialists, often with complex plans to repair or even bypass the artery. It's major, major surgery.
I feel like that's one of those rules that must be written in blood. Do not biopsy the pulsing lump.
It absolutely is, and it's the kind of mistake you only make once because the outcome is so devastating.
All right, let's dial down the adrenaline for a second and look at Section 5. Sudden impact and soft lumps. This covers traumatic and miscellaneous swellings.
Traumatic swellings are pretty intuitive, but they require very quick action. If someone has suffered blunt trauma like from a car accident or a sports injury or a penetrating injury and they develop a swelling, it's usually a hematoma, which is a collection of blood, or a pseudoaneurysm.
And the urgency here is obviously high.
It is, but not just because of the blood loss. The real urgency is because the neck is such a tight space. It's a cylinder bound by fascia. If you have a rapidly expanding hematoma, it has nowhere to go but inward. And it can compress the windpipe.
So it can actually choke you from the inside out.
Precisely. So the number one priority is airway protection. That is the absolute first step. You secure the airway. Sometimes that means needing to intubate the patient. And then, once they're stable, you worry about imaging or fixing the bleed.
Airway first, questions later. Makes total sense. Now, what about the miscellaneous stuff? The notes mention lipomas. These sound much friendlier.
They are. They're the good guys of neck lumps, relatively speaking. A lipoma is just a benign tumor of fat tissue. It can happen anywhere in the body, but the neck is a very common spot.
How does it feel compared to that hard, scary cancer node we talked about?
Totally different. A lipoma is soft. It's lobulated, meaning it feels a bit bumpy, almost like a little bag of frozen peas under the skin. But it's soft, and the classic description is that it slips under the fingers.
Slips.
Yes, the slip sign. If you press on the edge of it, it tends to slide away from your finger. That's because it's encapsulated fat sitting in loose tissue. It's mobile and squishy.
That's a pretty good rule of thumb, then. Soft, mobile, and slow-growing usually equals benign.
Exactly. It doesn't mean you ignore it, but the panic level it's much, much lower.
So we've covered all the types. Now I want to talk about the process. Section 6 is the Sherlock Holmes method. This is the systematic clinical approach. The notes list 7 questions that every clinician needs to run through. I love this because it feels like a checklist for solving the crime.
This is the checklist, and you cannot skip steps. When you're taking the history and examining the patient, you are building your case.
Question 1, age. We've hit this pretty hard already.
And we have to. It's the biggest context clue you have. You simply cannot interpret a neck lump without knowing the age of the patient. Child equals likely inflammatory or congenital. Adult equals you have to rule out malignancy. It sets your entire framework.
Question 2, duration.
Acute versus chronic. Has this been there for days? If so, you think infection. Has it been there for months? Think tumor or TB. Has it been there for years? It's probably a benign congenital cyst or a lipoma that's been there forever.
Question 3, pain.
We discussed this one too. Pain usually points to inflammation because inflammation irritates nerve endings. A painless lump is more suspicious for neoplastic or TB, as tumors often grow silently until they start to impinge on something.
Question 4, number. Single versus multiple.
Right. Multiple nodes often suggest a systemic issue. If you have lumps on both sides of the neck, and maybe in the armpits or groin too, you start thinking about things like lymphoma, HIV, or tuberculosis. A single solitary hard node makes me hunt for a very specific primary tumor in the head and neck.
Question 5. Consistency. This seems like the most important tactile one.
It is. This is where your hands do the real work. Is it hard, like a stone? That's carcinoma. Is it soft? That's a lipoma or a cyst. Is it matted? That's TB. Is it kind of rubber-like? That texture is classic for lymphoma.
Oh.
That texture tells you the pathology.
Question 6. Mobility.
Fixed equals bad. If it feels like it's glued down to the deep muscles, that suggests invasion. Mobile generally means better, suggesting it's contained within its own capsule.
And finally, question 7. Relation to swallowing or tongue movement.
This helps with that anatomical localization we talked about. If you ask the patient to stick out their tongue and the lump moves upward, it is connected to the thyroglossal tract, a remnant from development.
Okay.
If you ask them to swallow and it moves up and down, it's thyroid or larynx. It's a simple mechanical test that can tell you exactly what structure is involved.
It's amazing how much you can figure out just by asking the right questions and touching the neck before you ever even order a scan.
That is the whole philosophy of clinical medicine. The clinical examination narrows the diagnosis before you order the test. You shouldn't order a CT scan to find out what you're looking for. You order it to confirm what you already suspect.
Right.
If you rely only on technology, you will miss these subtle but critical clues.
Speaking of confirming, let's go to section 7, proving the case. We've talked about investigations a bit, but let's formalize the toolkit.
The toolkit is surprisingly simple. The heavy lifter, the most important tool, is FNAC.
Fine needle aspiration cytology. You've mentioned it a few times. Why is it the investigation of choice? Why not just cut a piece out to be sure? An open biopsy seems more definitive.
It's all about safety. FNAC is safe, it's cheap, and it's rapid. But the single most important reason we prefer it over an open biopsy is to avoid seeding the tumor.
Seeding, what does that mean?
Okay, imagine you have cancer neatly encapsulated inside a lymph node. It's contained. If you take a scalpel and you cut into it for biopsy, you break that capsule. You might spill microscopic cancer cells into the wound and the surrounding healthy tissue.
Oh, I see.
You've just disrupted the natural planes of the neck. If that happens, any subsequent curative surgery like a neck dissection becomes much more difficult and less effective because the cancer is no longer contained. You've let it out of the bag.
So a fine needle is safer because it keeps the package sealed, so to speak.
Exactly. It extracts the cells you need for a diagnosis without disrupting the tissue architecture. We only do open biopsies if the needle fails repeatedly, and even then, the surgeon is usually prepared to proceed to a full neck dissection right then and there if it comes back positive on the spot.
That makes a lot of sense. What about imaging?
Ultrasound is usually the first step. It's non-invasive, and it's great for distinguishing solid lumps from cystic or fluid-filled ones. Then we use CT or MRI to see the deep picture. How deep does the tumor go? Does it wrap around the carotid artery? Is it pushing on the esophagus? It gives you the roadmap for surgery.
And just to reiterate the safety warning one more time.
Do not biopsy vascular lesions, please. Always check for pulsation before you stick a needle in anything in the neck. That is how you lose a license and a patient.
Now, regarding surgical principles, the notes say, surgery follows diagnosis, it does not precede it.
This is a golden rule of surgery. You must know what you are cutting before you cut. Are you going in to drain an abscess? Are you removing a thyroid? Are you doing a radical neck dissection for cancer? You cannot just open the neck to take a look.
No exploratory surgery in the neck.
No. The anatomy is far too critical. You have the vagus nerve, the phrenic nerve, the carotid artery, the jugular vein, all packed into this tiny space. You need a map before you enter that territory.
It's the measure twice, cut once philosophy, but with much, much higher stake.
Exactly right. Blind exploration in the neck is just a recipe for disaster.
We're coming down to the wire here. Section 8. The exam gauntlet. These are the rapid-fire traps. These are the specific ways students and maybe even doctors can fail this topic. I'm going to throw the trap at you, and you tell me why it's a trap.
Let's do it.
Okay. Trap 1. Forgetting the adult rule.
The trap is seeing a neck lump in a 45-year-old and giving them antibiotics for 2 weeks, assuming it's just an infection because it looks innocent. The reality is you are potentially delaying a cancer diagnosis by 2 critical weeks. Adult swelling is malignancy until proven otherwise.
Trap 2. Doing an excision before an FNAC.
We just covered this. You biopsy an unknown lump, you risk spreading cancer cells through seeding, or you create a non-healing TB sinus. FNAC first. Diagnosis first. Always.
Trap 3. Confusing TB with acute inflammation.
The trap is treating a cold abscess like a hot one. If you slice open a TB abscess thinking it's a simple boil, you cause a chronic fistula, a non-healing wound. You have to remember, TB is painless and matted. Acute inflammation is hot and tender. Don't confuse the two.
And trap 4, biopsying a pulsatile mass.
The fatal trap. You assume it's just a lymph node sitting on an artery, you stick a needle in, and you puncture the carotid artery or a highly vascular tumor called a chemodectoma. Always, always, always check for pulsation.
It really seems like the common thread here is that exams and real life are testing pattern recognition and, above all else, safety.
Safety is the ultimate metric. A doctor who knows when not to cut is often a much better doctor than one who is just eager to cut.
Well, we have covered a massive amount of territory today, from the Big Five classification to the life-saving do not touch rules. As we wrap up, let's do a final 10-point recap for the listener who wants the cheat sheet.
Okay, rapid run-through. Let's do it. 1. Acquired neck swellings are critical, especially in adults.
2. Malignancy is the most common cause in adults.
3. A tender swelling equals inflammation.
4. Matted nodes equal tuberculosis.
5. Hard fixed nodes equal metascular.
6. FNAC is the investigation of choice.
7. Pulsatile swellings are vascular.
8. Never biopsy a vascular lesion.
9. Surgery depends on the diagnosis. Don't cut blindly.
And 10. Anatomy guides your management.
That's it. Concise and powerful.
And if you could add one final concluding thought,
Right.
what would it be?
It all comes back to anatomy. I know we keep saying it, but it's true. The neck is a superhighway for the body. Everything going from the brain to the rest of the body, blood, nerve signals, air, food, it all passes through this narrow cylinder. When you see a lump, you're seeing a disruption in that traffic.
A roadblock.
A roadblock, exactly. And by understanding the anatomy, by knowing the map of that highway, you can predict what the lump is and how to treat it safely.
That's a great visual. It turns the anatomy from a dry diagram into a living, moving system.
Yeah.
And I'll add my takeaway. Safety first. Age matters. Consistency matters. Don't just look at the lump, feel it, listen to it, and think about the person who is attached to it.
Couldn't have said it better myself.
So next time you look in the mirror or see a character in a movie with a lump on their neck, maybe you'll start to visualize the anatomy underneath. You might wonder, is that matted? Is it pulsatile? Does it move when they swallow? Just maybe don't go diagnosing your friends at dinner parties.
Or do. It might save a life.
Fair point. Thanks for guiding us through the anatomy lab today. It was fascinating. And to our listeners, thanks for diving deep with us. We'll see you on the next one.
Goodbye.
Stay curious.